part of the today's CME as a main speaker to speak on the clinical effects of bisoprolol across the cardiovascular continuum. So at the outset, I thank the Merck people for arranging a nice CME on one of the important molecule, as our presidents are told that the bisoprolol is the one of the important molecule for today's practice, not only in the management of the hypertension, but also in the management of ischemic heart disease and heart failure. So these three are very, very common in our day-to-day practice: hypertension, IHD, and heart failure. And in the next few minutes, I will throw some light on these issues and how your bisoprolol will help for these population. See, first we will talk about the coronary artery disease burden in India. See, as you all know that India is a very, very good country with a high number of the diabetics and hypertensives in the society. So obviously, if you see the major risk factors to cause the coronary artery disease, there are the 5 major risk factors to cause the coronary artery disease in Indian population. One is hypertension, then the diabetes, then dyslipidemia, obesity, and smoking. So these 5 are the important risk factors to cause the vascular diseases, and there are the several other risk factors like your dyslipidemias or your hyperuricemia, hypoalbuminemia, or hyperalbuminuria, or carotid intima media thickness, or ankle brachial index. So these are all the other risk factors to cause the vascular diseases in India. So if you see the diabetes and hypertension, I think these two are the very, very important. And if you see the prevalence, about the 11% for the non-diabetics coronary artery disease, and if they are diabetic, double the prevalence or double the incidence. So all the diabetic individuals, they will have a 2 to 4 fold risk of getting the coronary artery disease in Indian population. And the 3 times higher CAD rates in the Asian Indians even after the migration. So that clearly shows that our genes, our race, are more prone to get the diabetes, hypertension, and coronary artery disease. And 1 in 4 deaths in India are now because of the ischemic heart disease. So the commonest cause of the death in diabetes is the myocardial infarction. The commonest cause of the death in the hypertension is again a cardiac death. So these are all the vascular deaths. So 1 in the 4 deaths in India is because of the IHD, just because of the increased incidence of the diabetes and hypertension. There is an accelerating trend about the 50% increases between 2007 to 2017, and this trend increases. So today maybe the 55 to 60, 56% trend will be there in increasing the incidence of the coronary artery disease. See, all these figures are very important, and one most important thing here is we are getting the disease at an younger age. So diabetes occurring at an younger age group, hypertension occurring at an younger age group, even not at the 40 or the 50 years of the age group, even at the 15 years, 16 years, by the time they enter into the professional colleges, so they are hypertensive. By the time they are finishing their careers, maybe at the 21 years, 22 or 23, they are the diabetics. So if you see that at the age of 30 and 35 years, so 30 to 40% of the Indians, adult are having these ischemic heart diseases. So what are the certain unique features of the Indian coronary artery disease population? As I told you that younger age at the presentation, because of the younger age of diabetes and younger age to get the hypertension and the rapid progression. See, these coronary artery diseases are rapidly progressing in our population. So if you get the angio at the age of 25 26 years, about the 40% block. So we say that you don't require any stent, but please manage your risk factors like your diabetes or hypertension or obesity or smoking, etc. And the next year, if you get the angio again, so then the block will be 80% or 90%, and they require 1 or 2 stents. So that shows that the rapid progression of these vascular diseases are very common, just because of the increased incidence of the endothelial dysfunction. So we have to respect our vessels. See, the vessels are the very, very important organs in the body, along with your brain or the liver or the kidneys. I think the vessels are also very, very important. So to reduce the endothelial dysfunction, so we need to control the diabetes, hypertension, dyslipidemia, and obesity very drastically. And high mortality rates. See, if you see the mortality rate in the Western population, maybe 10 to 15%, whereas here to the tune of about 40 to 50% of the mortality rate. and it is a multi-vessel disease. So most of our people, they will have the 2 or the 3 or the 4 vessels blocked with the thrombus, and ultimately they need the CABG. And the diffuse coronary artery involvement. So entire coronary artery of your left anterior descending artery or the left main coronary artery or your right coronary artery or circumflex arteries, a diffuse involvement of the atherosclerosis is seen in these vessels, and it is very, very difficult to put 1 or 2 or 3 stents in those arteries, and finally they need CABG. And the distal disease, a proximal disease, we can easily put the stent. For the distal diseases, it's very, very difficult. Again, they are the candidates to go for the CABG, otherwise they will have a microvascular angina. Significant left ventricular dysfunction at the presentation. So this is a very, very important point, because we often do the 2D echo at the presentation and it shows 30%. So that shows your systolic function is only 30% or 40%, less than the 50%. It's a very, very common. We often see the people with the ejection fraction of 22%, 28%, 29%. Less than the 30% is also possible for most of the people because of uncontrolled diabetes, uncontrolled hypertension, and dyslipidemia. So if you see all these things, and definitely our Indian CAD population are unique when compared to the Caucasians. So what are our goals of the medical treatment in these population? So reduce the frequency and the severity of the angina, thereby improving the quality of the life. So improve the different drugs and reduce the future cardiovascular events. So that means you have to control all the other risk factors. Even though the person is a diabetic, you have to see whether he is an hypertensive or whether he is a dyslipidemia or the obesity, etc. We have to control those things also to reduce the future cardiovascular events. And definitely we have to improve the survival, and most important thing is the quality of the life. So we have to improve the quality of the life of all these population by your 360 degrees examination or the treatment of these blocks. See, coming to the topic proper, the beta blockers, they are the well-established cornerstone in the pharmacological management of IH. Say, when we were undergraduates, one of the important contraindication to use the beta blockers is your ischemic heart disease, or your bronchial asthma, or your COPD, or the peripheral vascular disease. So these are the different contraindications to use these beta blockers. But now the beta blockers are the very, very important drugs to be used in the ischemic heart disease. Why? They regress the erythromatous process. They reduce the rate of the reinfarction, reduce the infarct size and the risk of the cardiac rupture, increase the threshold to the ventricular fibrillation. They reduce the platelet thickness, reduce the myocardial oxygen requirement because they reduce the heart rate. They reduce the systolic blood pressure. In some cases, they also reduce the diastolic blood pressure. They reduce the ventricular contractility. So these are all the things which are very, very, very useful in the management of IHD. So for that reason, beta blockers are the very, very important drugs to be used in the IHD. In fact, they reduce the mortality. Suppose if you use the digoxin in the cardiac patient, they may not reduce the mortality. If you use the GTN sarbitrates, they may give the symptomatic relief, but they don't reduce the mortality. But the beta blockers are the very, very important drugs to reduce the mortality because of these multifaceted actions in reducing the heart rate, in reducing the contractility, in reducing the blood pressure, and improves the oxygen carrier capacity in the vessels. So the beta blockers used in the stable CAD according to the geographical region. And if you see the different countries like Europe or the Russia or the South America, South Africa and Asia, and in our country, we use more of the metoprolol. If you see the unique description of the cardiologist IHD, so mostly the Metexel 25 mg or Metexel 12.5 or 50, etc., etc. But now bisoprolol is gaining up. So the most important and most promising and most rising drug of the beta blockers in India and also across the world is the bisoprolol, just because of these differential features the bisoprolol is having when compared to the other beta blockers like propranolol, atenolol, metoprolol, nebuvolol, carvedilol. So these are all the beta blockers we often use in day in and day out, and I will come at a later time the advantage of the bisoprolol over these other drugs. So the bisoprolol is used commonly in the current practice for the ACS. Every year, the beta blocker usage is increasing because of the increased IHDs in the country. At the same time, the bisoprolol is forced over the other beta blockers because of its unique activities. So there is a lot of the evidence exists for the bisoprolol. If you see, these are the names of the different studies. Teams, they reduce the number of the angina attacks if you use the beta blocker like bisoprolol. And then the real world evidence in the non-ST elevated myocardial infarction offers the cardioprotection. Clarify history, most widely used beta blocker globally is the bisoprolol. And bisocard study, efficacious in lowering the, and also in the Asian patients. In the same way, there are the different studies they commonly use it that they say that bisoprolol may be considered as the first choice as per the Cochrane review. See, what are the association of the beta blockers therapy with the cardiovascular outcomes in patients with the stable ischemic heart disease? See here, they have used this bisoprolol for the longer period. So actually from the 2009 to 19, about the 10 years in Canada. So the median follow-up is up to the 5.2 years. They say that atenolol 4.6, metoprolol 29, and the bisoprolol is the 66%. Significant reduction in the composite of all-cause mortality and hospitalization beta blockers over the 5 years the stable IHD. So if you use these beta blockers, there is about 13% relative reduction in the risk of the hospitalization of the myocardial infarction. Beta blockers provide the consistent benefits for the primary outcomes in the various subgroups. See, these are the different subgroups like your male and the female, or your age, or the previous revascularizations, or any risk of ischemic risk, or multivessel disease, left main disease. So these are the subsets where the beta blockers provide a consistent benefit for the primary outcome of the various subgroups. In all the subgroups of the IHD, so you can use the beta blockers. Long-term effectiveness of the bisoprolol in patients with the angina. And if you see here, it's the largest and the longest. They have the mortality and the CV outcomes are the better if you use the beta blockers like bisoprolol. There is a significant improvement in the survival with the bisoprolol in patients with the angina. It's a protective effect sustained over the 14 years. So not the 6 months or the 1 year. So the lower the discontinuation rate, about 12.9% versus the 19% in other beta blockers cohort. So you have a significant benefit in terms of the incidence of the angina or the embolism or secondary myocardial infarction and arrhythmias. So that will be useful in usage of the beta blockers like bisoprolol. See, nowadays we are seeing a lot of the tachyarrhythmias, especially after the post-COVID. Heart rate will be 110 or 120, and there will be the atrial fibrillation, and there is supraventricular tachycardia and embolisms. So in all these things, you can safely use the bisoprolol to reduce the events. Biso effectively lowers the rate and causes a significant decrease in the composite cardiac outcome. So it improves the prognosis and also the independent of the BP lowering effect of the bisoprolol. So not only the reduction of the blood pressure, the molecule itself will reduce the endothelial dysfunction so that it will have a positive effects. In arrhythmias, already I told you the supraventricular arrhythmias and the ventricular arrhythmias. So they improve the symptoms and the quality of the life and reduces the mortality and reduces the number of the hospitalizations and lowers the burden of the ventricular arrhythmias. So the bisoprolol. So the take-home messages from the cardiovascular CAD point of view, they are used in the patient the CAD to reduce the harmful effects of the excessive adrenergic activation on the heart. Wealth of evidence exists that bisoprolol CAD, including the coronary syndromes, greater mortality reduction in the CAD patients at largest and the longest. Effective reduction in the MACE in Asian patients with the bisoprolol. Improvement in the left ventricular ejection fraction and other cardiac functions and the parameters in tenacity and other studies. So the bisoprolol in coronary artery disease is a good molecule to be used. So for that reason, if you see the case sheets of the post MI or post PTCA or post CABG, and one molecule must be a beta blocker because they reduce the mortality and reduce the heart rate, etc. And whenever the heart rate is more than the 90, earlier we consider that tachycardia means more than the 100, bradycardia means more than the 60. But nowadays, for all the practical purposes, more than the 90 you should consider as a tachycardia. So once the heart rate is more than the 90, it's always better to use the beta blockers like bisoprolol to reduce the heart rate to somewhere between 70 to 80. Now move on to the second topic, that is the heart failure in India. You all agree with me that the chances, the cases of the heart failure are increased in the society because of the increased geriatric population. So the aging of the population So definitely the most of the people will have the heart failure. So now in India, there are the 4 causes to cause the heart failure. Number 1 is ischemic heart disease. Number 2 is the diabetes. Number 3, hypertension. Number 4 is the rheumatic heart disease or postpartum cardiomyopathy or viral cardiomyopathies like post-COVID, etc. So you all agree with me that coronary artery disease incidence is very increasing in India. So that is the number 1 cause for the heart failure. See the prevalence of the heart failure around 1% of the total population. See in a country like 140 crores of the population in India, and if you say that 1% of the total population, the number is very, very high. See, the beta blockers are the cornerstones and integral part of the guideline directed therapy for patients with the heart failure with the REF. REF means reduced ejection fraction. Now the heart failure is divided into the 3 groups. Heart failure REF, that means reduced ejection fraction when your EF is less than the 40. Heart failure PEF. PEF means preserved ejection fraction. That means your EF is more than the 50. Now you have the one subset where the EF is less than 40 and the second one is more than the 50 and the third group is between 40 and the 50. So less than the 40 EF we consider that REF, reduced ejection fraction heart failure. More than the 50 ejection fraction we consider the PEF, that is a preserved ejection fraction. Between 40 and the 50 mid-range ejection fraction. So the heart failures are the 3 types now, 3 different groups. In all the groups, you have to use the 4 drugs. These 4 are the main pillars in the management of the heart failure. So one pillar is the ACE inhibitors or ARB or RD. RD is nothing but a combination of the valsartan and the sacubitril. And the second pillar is the beta blocker. And the third pillar is the MRA. MRA means melanoreceptor antagonist, like your spironolactone. And the second MRA is entered into the market and doing very well, doing extremely well. That is the pheneranol. That is a non-steroidal MRA. So these 2 drugs are the MRAs now in our hand. One is the spironolactone. The second one is the pheneranol. And of course, the fourth pillar is the SGLT inhibitor, even in the non-diabetic individuals. So once your diagnosis is the heart failure, whether it is a diabetic or non-diabetic, one of the pillars to be used is the SGLT inhibitors. So SGLT inhibitors are sodium glucose receptor blockers like dapagliflozin or empagliflozin or canagliflozin. So the DAPA is very important drug to be used in the heart failures. So start early. That is the class 1 recommendation is the 4 drugs. So already told you. One is the RNA, that is your Vimada, sacubitril and valsartan combination. The second one is the beta blocker, that is your bisoprolol. And the third one is MRA. So the poor people, you use the spironolactone. Those who can afford, we use the pheneranol. And the fourth one is the SGLT inhibitors like dapagliflozin. So if your diagnosis is the heart failure, so this treatment must include all these 4 drugs. That is your 4 pillars. And now the 5th pillar is also entered. That is the Vesugard, which improves your nitric oxide in the vessels. So you all know that nitric oxide is a potent vasodilator. So to improve the nitric oxide in the vessels, you can use the Vesugard. So these are the important class 1 recommendations are the most important. And then in some of the heart failure population, if you need a diuretic, so the presence in the venal edema, JVP is very much elevated, there is an ascites, and there is a hepatojugular reflex. In such situations, you have to use the diuretics, and spironolactone is not a potent diuretic. There you have to use the loop diuretics like your furosemide or the torsemide. Evaporating, as I told you that heart failure, so heart rate more than the 100, in spite of your beta blocker therapy, in spite of your bisoprolol therapy, still the heart rate is more than the 90, then you can use the evaporating. That is available in 5 milligrams BD. So you can, that is a good drug to be added. Hydrogen and nitrates, so they are the central acting drugs, is a vasodilator, hydralazine. So that also you can use along with the nitrates. And Omercat2 is not available in India, but the Vesugard already I told you, very Q 2.5 mg and the 5 mg and the 10 mg. So in heart failure, the most important drugs are your RD, that is your Vimada or Secuban, etc., and your spironolactone, pheneranol, or dapagliflozin and bisoprolol. And then the heart rate is more, you can add the evaporating. And if they need the diuretic, pedal edema, etc., or paroxysmal nocturnal dyspnea or orthopnea, you can add a Lasix or the torsemide. So these are the very important drugs to be used in heart failure. So one of them is a beta blocker, and the relative risk reduction with the 4 pillars of the heart failure. Already told you these pillars, and beta blocker is a very important drug to be used in these conditions. So the relative risk reduction is about 73% with the number needed to treat of 4 to prevent death. So it's a reduced mortality. So as I told you, that is a mortality reduction drug and good quality of the drug. So the red one, center one, is the moderate dose. So even though you start with the 2.5 milligrams of bisoprolol, 5 milligrams of bisoprolol, most of our people, they need 5 mg or 7.5 mg or the 10 mg. So don't be happy with the 5 mg alone. When the heart rate is more, definitely have to increase the dose of the bisoprolol to 7.5 or the 10 mg. Suppose you start with the 5 mg, the heart rate is 40. What to do? So you should not stop the bisoprolol. You have to reduce the dose of the bisoprolol to about 2.5 or even 1.5 also. So to use the bisoprolol, you have to see the heart rate. Of the deaths in the patient with the heart failure, up to 50% sudden and unexpected, because heart failure diagnosis itself is a very dustbin diagnosis because they need more and more hospitalization. And even the mortality in the hospitalization is also very high. So that is the reason. So sudden and unexpected deaths are very common in the congestive heart failure population. So by the time you leave the hospital at 10 or 11 p.m., they are very good. But they are going to die at 3 a.m. or the 4 a.m. because of this heart failure. So heart failure is nothing but, so there is a defect in the myocardium. So there will be the ejection fraction is very low, maybe 20 or 30%. So they are more prone to get the arrhythmia. See, as I told you, you have to use the spironolactone. So spironolactone causes hyperkalemia. So once the hyperkalemia sets in, so that causes tachyarrhythmias. In the same way, so the drugs itself will kill the patient. So that is the reason that dosing of the drugs is also very important once your diagnosis is heart failure. In the same way, if you use the acids or the torsemide without checking your electrolytes, so they may cause hyponatremia. So sometimes, if you see the patient is very drowsy, and if you check the sodium, it is 100 or 110 or 120, so less than the 135. So that shows the patient is in severe hyponatremia, where you should stop using the diuretics and start using the 3% NS or natrites, etc. So the electrolyte imbalance is also very important in the heart failure. That could be one of the trigger point to cause the sudden cardiac death. So the bisoprolol given in addition to the standard therapy significantly reduce the all-cause and CV morbidity and mortality. So these are how all-cause mortality is reduced by about 34% when compared to all other drugs with the bisoprolol. In the same way, if you see the sudden deaths reduction is also more with the 50 and 46% with your bisoprolol. Switching from the carvedilol, earlier we used to use the carvedilol in the presence of the heart failure, maybe the dose of 1.25 or 3.65 or the 7.5, etc. But nowadays we are not using much the carvedilol because of the good effects of the bisoprolol. See here, dizziness and hypotension. After using your bisoprolol, they have reduced it very much. The dizziness and hypotension. Compared to the carvedilol, bisoprolol decrease all-cause mortality in the congestive heart failure population. These are the different studies. All studies favors the bisoprolol, and no, not a single study favors the carvedilol. On the right side is the bisoprolol favorable. Bisoprolol combined with the RD, that is your Vivador, Salbutamol, Valsartan combination in the cardiac rehabilitation of the patient with acute myocardial infarction, combined with the LVF, left ventricular failure after PCA. So bisoprolol combined with the RD has a good application effect in the cardiac rehabilitation. Advice to cardiologist late వచ్చాం help బయట help. In heart failure, 97.5% patients have the comorbidities. So these are very important. So once you diagnose the heart failure, it's very easy to diagnose the heart failure. Even an house surgeon also can diagnose the heart failure. There is the fatal edema, PND, elevated GVP, very well. But one thing is very clear that once you diagnose the heart failure, so what are all the comorbidities the patient is having? Unless you address the comorbidities, again the sudden cardiac deaths are very common. So the common comorbidity here is the diabetes, atrial fibrillation, COPD, and the CKD. And CKD is very high in the society right now. So you all know that in Kakinada in 90s there are only 2 dialysis missions, but now there are more than 250 dialysis missions working 4 shifts a day. Sometimes now 5 shifts or 6 shifts a day. So imagine the number of the people who are at dialysis right now. So just because of the increase in number of CKD, because of the two reasons in India, one is uncontrolled diabetes, uncontrolled hypertension. So again, as a basic doctors, irrespective of your specialty, you should pay a lot of attention to the diabetics and hypertension. So you don't require any general medicine or endocrinology or cardiology or nephrology to treat the diabetes and hypertension. Every basic doctor should have a clear-cut knowledge in the management of the diabetes and hypertension. Unless you control the diabetes and hypertension very effectively, and most of these people will be having the CKD, most of these people will have the IHD, most of these people will have the CVA, most of the people will have the PVD and they lose the limbs, and also they have the retinopathy and they lose the sight also. So this is a very, very important comorbidity one should address. Suppose if the patient is having the diabetes and the heart failure, so definitely you have to use the some drugs which will not increase the heart failure like saxagliptin, or the metformin is contraindicated in the heart failure because hypoxia. In the same way, saxagliptin is contraindicated in the heart failure. So you have to use the few drugs which are very useful in the heart failure with the diabetes, like your again the sulfonylurea should not use it because they cause hypoglycemia. Hypoglycemia will precipitate the heart failure. So very few drugs are there in your hand. The people with the heart failure, maybe like your ఎంతో స్టార్ట్ అవుతుంది విక్టిన్ Lenactinib. So the lenactinib you can use safely. Sitagliptin you can use safely, and sometimes you can use the dapagliflozin because they have to use its own pillar, and then finally you have to go for the insulin. Insulin like your basal insulin like Glargine, Lantus, or your regular insulin, etc. That's how you have to treat the diabetes in heart failure. Atrial fibrillation in heart failure, as I told you that bisoprolol will act here, and you can add these rate limiting drugs like your evaporating you can use here, or you can use the rivaroxaban etc. to reduce the embolic strokes. So these are very important. Low molecular heparin or rivaroxaban. So we use these drugs in the COVID era. COPD is a big chapter. Nowadays it's increasing because of the increase in pollution, and I think the 70 to 80% of the Delhi population they are the COPDs right now. If you see the lungs, lot of the lungs are very, very dusty. So in the COPD, they need the oxygenation, inhalers therapy or nebulization. They are very, very important. CKD already told you it's a very big topic. In all the CKD population, you have to address the anemia because here, any terms of your iron won't improve your hemoglobin unless you introduce the erythropoietin. So it may be available in the 4,000 units, 6,000 units, 8,000 units once in a week or twice in a week, sometimes thrice in a week. You have to add the erythropoietin to control to improve your hemoglobin in CKD population. In the same way, the CKD population they are more prone for osteoporosis. So here you have to use the good amount of the calcium, and they are more prone for the vitamin D deficiency. Now 80% of the Indians are vitamin D deficient. So you have to use once in a week 60,000 vitamin D or once in a month lifelong. So these are the very, very important parameters to be used in the CKD. And one important thing about the CKD is the Western book says that protein restriction. But for Indian CKDs, you need not restrict the protein because our diets are very, very poor in protein as per the CKD population is concerned. So you can give milk, you can give the egg, you can give the chicken also. So in all the CKD population, only the pieces, not the gravy, to improve the protein content and the dry fruits and the nuts. So they are very, very important. Comparative effects of the carvedilol and the bisoprolol for severe CHF. So definitely the bisoprolol scores out the carvedilol here. And increasing the beta blocker dose was associated with the lower mortality. The coexistence of the heart failure and the COPD. So again, I told you earlier, COPD is a contraindication to use the bisoprolol, but bisoprolol can be safely used in the COPD because it has the better beta-1 selectivity. So the beta-1 selectivity means lower respiratory side effects. Whereas if you use the atenolol or the metoprolol, they have both the beta-1 and beta-2 selectivity. So they have the lung side effects like dyspnea, etc. But in bisoprolol is more of the beta-1 selectivity. So you don't have any exacerbations of your COPDs or asthmatics. So you can safely use the bisoprolol in COPD and asthmatics. Relative to the carvedilol, bisoprolol initiation in the hemodialysis patients was treated with the lower 2-year risk of the death. So even in the CKD population, you can safely use the bisoprolol because the excretion is both the liver as well as the kidney. So in the same way, you can use the bisoprolol in the CKD population also. Whereas your metoprolol, your atenolol, and other drugs, other beta blockers are contraindicated the CKD. CKD means, as I mean to say, CKD means on the creatinine level is 5 or 6 or 7. Those who are at the hemodialysis, so definitely the beta blocker of choice is the bisoprolol. So the bisoprolol on all-cause mortality is also very, very low. It's a favorable pharmacokinetic profiles and also pharmacodynamic profiles because the nearly complete absorption, small first pass effect, high absolute bioavailability, independent of the food intake, you can give with diet or without diet, and empty stomach also. Mixed route of the elimination, as I told you, hepatic and the renal 50-50, so that you can use it even in the hepatitis or even in the renal failure. Not in the exaggerated severe stage, maybe in the mild and moderate stages, you can safely use these drugs. So the take-home message as far the bisoprolol the heart failure is concerned, it is a cornerstone in the treatment of the heart failure that reduces. I told you 4 pillars, and one pillar is a beta blocker. And among the beta blockers, bisoprolol is the drug of choice. It has a proven efficacy in the landmark trials, more effective than other preferred molecule in COPD, atrial fibrillation, CKD, and on hemodialysis. And don't use the carbonyl, use the bisoprolol here. Initiate only if the patient is stable or have compensated heart failure. Start at the lowest possible dose, and then usually you have to uptitrate the drugs. See, in all these populations, whether in IHD or heart failure or in arrhythmias, always in cardiology you start with the low dose only. Even when we start the ramipril, that is our cardias, we start with 2.5 mg in most of the cases. And some people they may require 20 milligrams also, ramipril 10 mg BD also, but we always start with the 2.5 milligrams. So it is the highest beta one selectivity. That is the reason you don't have any respiratory side effects. And minimal effects on the lung function, minimal effects on the lipids, minimal effects on the glucose, minimal effects on the male sexual dysfunction, unlike your etenolol and metoprolol, minimal effects on the peripheral circulation. See, if you use the traditional beta blockers, they have the side effects on the glucose metabolism, they have the side effects on the lipid metabolism, they have the side effects on the uric acid metabolism. So if you use the bisoprolol, you don't have these side effects, and all these side effects are very, very useful to reduce the incidence of ischemic heart disease. As I told you, the traditional and the non-traditional risk factors. I told you hyperuricemia, I told you hypoalbuminemia, I told you the microalbuminuria. So these all things can be reduced with the bisoprolol usage. So the pharmacological variability of the commonly used beta blockers, and if you see this metoprolol, high variability, and bisoprolol is the lowest variability. This is the very, very important. In the same way, GB, glycemic variability in the diabetes. So the more the glycemic variability, the more the risk factors are the side effects, are the complications. In the same way, no drug should have a maximum variability. So you have to use the drugs which are having minimal variability. So here the bisoprolol is the drug which is having the lower variability when compared to the other beta blockers. So combinations bisoprolol plus amlodipine. So your favorite drug for the oral hypertension is amlodipine plus etenolol. So in that situation, you can use the amlodipine plus bisoprolol as your favorite beta blocker and calcium channel blocker. And bisoprolol and telmisartan. Now our favorite ARB in India is the telmisartan. 80% of our prescriptions is the telmisartan. And if you want to add beta blocker, add the bisoprolol. So this combination is available. And then the bisoprolol plus diuretic. So those people are the elderly population, so they definitely need a diuretic. And a diuretic we use according to your GFR. When the GFR is less than the 30, use only the loop diuretics like your Lasix or the torsemide. When the GFR is between 30 and the 60, so you can use the hydrochloroquine and chlorothalidone. So beta blockers can be used as the monotherapy or at any step of the combination therapy. Now the management of the hypertension is individualized. See, earlier we start with the diuretics, then the beta blockers, then the calcium plugs, etc. Now it is individualized. For example, if the person is more risk of getting the ischemic heart disease, so straight away we use the ARBs. When the fellow is having the high tachycardia, so definitely we have to use the beta blockers. If the patient is very elderly with the fatal edema, so definitely we have to use the diuretics. On the other hand, when the young female can want to conceive, so definitely we should not use the ACE inhibitors or ARBs or diuretics. So these are the contraindicated drugs in the pregnancy. So you have to use either the calcium channel blockers or the beta blockers in such people. On the other hand, when the creatinine level is 3 or 4, you should not use the telmisartan or any ARBs or ACE inhibitors. So there you have to use the calcium channel blockers like your nifedipine, etc., or alpha blockers like rosuvastatin, or central acting drugs like artemisinin, and then your loop diuretics. So that depending on the patient's profile, so you have to select the drugs. See the renin activity. See these are the different pathophysiological mechanisms to cause the hypertension. So there is a sympathetic nervous activity. So there is a RAS activity. There is a vasodilatation. There is a vasoconstriction, and there is increased heart rate, increased contractility. So there are different mechanisms to cause the hypertension in our individuals, and we have the different drugs to act on these things. So the hypertension in India is a very, very big topic, because if you see the ICMR India study, hypertensive individuals in India, to about 45 to 50 crores of Indians are having the hypertension. And if you consider as 130 by 85 is the hypertension, I think 80% of Indians are the hypertensive. So my definition of hypertension is systolic more than 140, diastolic more than the 90. So if you consider 140 by 90 as the hypertensive, 45 to 50 crores of Indians are having hypertension. And non-dippers. See, the normal blood pressure during the sleep should be less than 125 by 75. If it is more than 125 by 75 during the sleep, and it is called as a non-dipper. So the BP has to be reduced to a level of 125 by 75. So non-dippers, who are the non-dippers? Uncontrolled diabetics are non-dippers. Uncontrolled hypertensives are non-dippers. Obesity is a non-dipper. Excess alcoholism is a non-dipper. Excess smoking is a non-dipper. So these non-dippers are not good. Dippers are the good. Non-dippers are more prone for the ischemic heart disease. Have the OSCA, snoring. So again, the obstructive sleep apnea is a big risk factor for the vessels. So the more the people are having the obese and more the people are having the OSCA, they are more prone for the vascular events. Have high resting heart rate. As I told you, the tachycardia, not your 100. Even the more than the 90, you be careful. High renin levels. So high renin levels means more production of your AT2. So that is your, what is that? Angiotensinogen, angiotensin 1 and angiotensin 2. Yes, angiotensin 2 is the potent vasoconstrictor. So that angiotensin 2 production is because of the high renin levels. So you have to see all these subgroups. So here you have to use the drugs accordingly. And the early onset in the life, hypertension, as I told you. So in the first year of MBBS or first year of engineering, I think 10 to 15% of the people are hypertensive. Their blood pressure is more than 140 by 90 because of the other factors. Clustering of the multiple CV risk factors. So we are having the more risk factors, a strong family history, Indian race, abdominal adiposity, and then the hypertension, diabetes, etc. And significant seasonal variation of the blood pressure. So these are the very important things. Indian hypertension is sympathetically overactive. So I told you the pathophysiology, and sympathetic overactivity is the one etiology to cause the hypertension. And sympathetic overactivity can be controlled with the bisoprolol. So this combination of the bisoprolol and the telmisartan will act on the RAS activity, and bisoprolol will act on the sympathetic nervous activity. Hypertension can be divided into 3 groups: stage 1, stage 2, stage 3. In stage 1, the systolic will be between 140 to 160. 160 to 180 is the stage 2. More than the 180 is the stage 3. And diastolic 90 to 100 is the stage 1. 100 to 110 is the stage 2. More than the 110 is stage 3. But unfortunately, most common symptom in the hypertensive is no symptom at all. So by the time they have the symptom, they will have the symptoms of the cardiac attack, or symptoms of the neuro, or the symptoms of the kidney, renal. So they will have the oliguria, they will have the excess sweating, or the breathlessness, or the chest pain, or loss of consciousness because of the complication. So don't expect the symptoms in hypertension. Symptoms usually with the complication. With a simple hypertension, they don't have the symptoms. So how to detect? So you have to check the blood pressure with your own hands. So stage 2, don't depend on the sisters for the BP estimation. So at least those people who are at high risk, so you have to see that the blood pressure, and also you have to see both the systolic and the diastolic. When the systolic is 120, so most of the people, they don't check the diastolic for the absence of your correct cuff sounds. See what happens in hypothyroidism, the systolic will be 120, but the diastolic will be 100. So that is called diastolic hypertension. So most of the hypothyroidism population, the systolic will be 120 or 130, but the diastolic will be 96 or 100. That means they are hypertensive. So unless you use an antihypertensive medication in those population, so they will be having ischemic heart disease and heart failure at a later time. So these are the important combinations, bisoprolol, etc. So they are fixed drug combinations. So thank you very much for your patient hearing. And if you have any doubts, I'm very happy to